Good afternoon, and thank you for joining us in the latest session of LHSN's Safer Care Accelerator webinar series.
My name is Dee Thompson, and I'm a policy fellow here at Imperial College's Institute for Global Health Innovation, and I lead on our LHSN program. We're thrilled to be joined today by Professor Jane Reid, who will be discussing the importance of human factors awareness and delivering safe and compassionate care. So Jane has a wealth of experience in acute care nursing as well as higher education. She served as the nurse advisor for the WHO Second Global Challenge, Safe Surgery Saves Lives, served as the president of the Association for Perioperative Practice, and as the nurse advisor to the UK's National Patient Safety Agency. Currently, Jane co-chairs the Learning to Be Safer expert group for Health Education England, and is the non-executive director of the Dorset County Hospital NHS Foundation Trust. She was also recognized by the Health Service Journal as one of the most inspirational women leaders in healthcare in 2013. So we're very excited that she's taken the time to go ahead and join us today. So now, without further ado, I'd like to turn it over to Jane.
Okay, thank you, Dee Dee. Just to explain, first of all, good morning, good afternoon, wherever you are in the world. So what I'd like to talk to you today is really about the work that we've been doing in the UK around raising human factors awareness and the importance of that science in terms of supporting care delivery, and just give you some background to some of the challenges that we've experienced in our healthcare system that really related to the way in which this work is being taken forward. So my objectives for this session really are to explore the compassionate caring context and consider the emotional labour of caring, whatever your professional role and whatever your contribution to your healthcare system. I want to talk a little bit about compassion, care and respect, both as a shared right and responsibility for the people we're responsible for in terms of their care delivery, but also for health professionals who provide the caring role. I'd like to explore with you how human factors ergonomic awareness and understanding is really important from the board to the frontline caregivers, and how that can help us in building emotional and organisational resilience to support the staff in their caregiving role. And I'd just like to outline with you and perhaps invite some questions and comments on the recent work that's been conducted nationally by the National Quality Board here in England, and a particular group called Clinical Human Factors Group, with which I'm affiliated, and I'd like to share with you some of the way in which we've been trying to integrate human factors and ergonomics understanding and application at scale for the NHS in England. So just by way of definition, and to make no assumptions that people are familiar with the terms I'm describing, human factors and ergonomics has a number of international definitions. But the definition that we're currently using and exploring and really apply to most of our work is the one on the screen in front of you, and that relates to enhancing clinical performance through an understanding of the effects of teamwork, tasks, equipment, workspace, culture and organisation on human behaviour, and the abilities and application of that knowledge in clinical settings. I think it's fair to say, if you look across many safety critical industries, human factors has been an organising principle in many systems, but it's been less well embedded in healthcare, and that's a journey for us all to take. So why in the first instance is it important? For me, and in terms of observations professionally, it can do much to set the organisational culture and the expectations of behaviours and requirements in an organisation. It provides direct support for frontline clinical teams. But crucially, if you look at other safety critical industries, it's not just about patient safety. Patient safety is a byproduct. If you look at other industries, it's about efficiency, effectiveness, productivity and performance. And ultimately, if you're a board or a senior executive member, it does much to provide the assurance that's required for public accountability for the services provided. So the picture on the right of your screen just seeks to reinforce some of the elements that are considered important. Fantastic observation by Albert Einstein there, just to set the context. The notion of setting example is not the main means of influencing others, it's the only means. And with regard to human factors and providing compassionate and safe care, what we arguably see is that a human factors understanding and awareness, and where the science is integrated within the system, can provide a much more open and transparent approach to care delivery. It increases the profile of patient safety and quality. It provides the context and the environment in which staff are much better supported to speak out and raise concerns, and to stop the lying when they observe deficits in care or deficits in system delivery. It strengthens roles and relationships of people in the team, board to front line, and ultimately encourages us to focus on the human impact of the services that we provide, and focus on the patients or service users who are in receipt of our care. Next slide. Just in terms of background and setting the scene as to the advance of this science in relation to healthcare. For those on the call who are familiar with the US health system, none of us can fail to ignore the impact, the powerful impact of the Institute of Medicine report back in 1999 to Err is Human, which qualified the scale of avoidable harm and error that was impacting on the receipt of patient care and patient services. Quite significant. That report in itself stimulated a focus here in the UK, and particularly the work led by our then Chief Medical Officer, Sir Liam Donaldson, who's now the Special Envoy for Patient Safety at the WHO, and resulted in a report called An Organisation with a Memory, which really invited the health system to focus on the value of learning from and reporting adverse events in the NHS. The focus was very much about improving the culture, learning from near misses, understanding error and accident causation. So that's the backdrop for where we are. And I guess one of the things that both of those reports highlighted, and we still continue to see today based on our mortality and morbidity reviews and the work that we collect nationally through the National Reporting and Learning System, is that we continue to observe an unacceptable variation in the quality of patient experience and clinical outcome. Here in the UK, we're still reporting statistics on average of 1 in 10 patients admitted to an inpatient bed suffering an adverse experience. And I guess, again, in terms of the backdrop and understanding where we are, it's worth qualifying that it's only relatively recently, up to 10 to 14 years, that we've actually accepted that, for the most part, the number of patients who are harmed when in receipt of care is less about their underlying illness or disease, but as a result of their treatment and the performance of the teams caring for them. Charles Vincent's work, initially at Imperial, now at Oxford, stemming back from 2001, invites us to consider, when analysing adverse events and harm events, that in the main, what we're looking at and what we're surfacing are the non-technical aspects of performance and team relationships, and how they play a contributory role in adverse events. On to the next slide, just some stories to put all of this in context. What you now have in front of you are 4 pictures of 4 quite important people. And to the right of my screen, you have a young gentleman there called Wayne Jowett in the blue pullover. Sadly, he lost his life in an adverse event relating to maladministration of chemotherapy drugs and vincristine. In the middle of your screen, you have a lady called Elaine Bromley, who sadly died in a can't ventilate, can't intubate scenario, undergoing elective care. And I'll refer back to Elaine in a moment, because her death stimulated the energies of Martin Bromley, her husband, to establish the Clinical Human Factors Group, which has been quite significant in lobbying for improvement and focus on human factors in the NHS in England. Top left, as I'm looking at my screen, is a young lady called Bethany Bowen. Bethany was a young child requiring an elective splenectomy for a congenital disorder, and who sadly, on the fateful day that she lost her life, was attended by a clinical team who decided to use, in the case of her procedure, a morcellator that had not previously been used in a paediatric context, and for which the attending physician was not trained. It invites the question of the hierarchy in the surgical team. It invites the question about what were the conditions on that day that made it acceptable to think that that would be an appropriate approach to care delivery. And then bottom left is the picture of a young boy referred to in our media and our national press as Baby P. This child, sadly, was the victim of quite horrendous parental abuse, was in receipt of social services and special safeguarding attention for his well-being. But sadly, between the interface between the police, social services and the healthcare system, his needs were not identified, and he suffered at the cruelty of his parents due to failures in communication, handoff and exchange. And then next slide, Dee, you have just a picture of a number of institutional failures that we've had to come to terms with here in the UK. Back in 2001, there was a major inquiry into the failures in a cardiac unit in Bristol, where many children died due to failures in service delivery. In 2007, we had more systemic failures in a hospital called Maidstone, where there were failures to do with infection control and infection and prevention, which resulted in many older people dying in the health system. Bottom right, reference to Winterbourne View, a tragic case, which if you Google it, you will see failures in the provision of care for patients and service users with a learning disability. And then bottom left, reference made between 2005 and 2009 of systemic failures in a hospital called Mid Staffordshire NHS Foundation Trust, which arguably is the catalyst for the work that I'm going to describe now. And if we look at other safety critical industries, whether we're talking about aviation, the nuclear industry or oil, all of those industries in the course of their history and their focus on human factors and ergonomics had their own systemic failures. So if we look at the oil industry, it might be Piper Alpha. If we look at the nuclear industry, it may well be Chernobyl. And if we look at the aviation industry, it's the major failings of the airline industry back in the 70s, which resulted in NASA focusing on the improvements that really needed to be required systemically and in relation to team performance and behaviour. So next slide. Here you have just an example of the types of variation that we're talking about. So whether it's pressure sores, deep vein thrombosis, issues to do with sepsis or medication error, or surgical failure in terms of surgical never events such as wrong site surgery, performing on the wrong patient. There are a number of areas where we can identify the harm that patients suffer and the variation that we have to address. This slide just provides you, here in England, we have a service called the National Reporting and Learning System, and this is a reporting system that's managed nationally. It invites organisations to report their harm, and what you see in front of you here is just a breakdown of the types of harm that have been reported, recognising, of course, that this is only the tip of the iceberg. And whilst harm reporting is as an indicator of a positive safety culture in organisations, we are appreciative that reporting could still be better than it currently is. And whilst we've been focusing on harm associated with variation in care. What we do know absolutely is that while we've got good understanding of what happens in hospitals, in acute care, we've got massive gaps in terms of what we understand to be happening in mental health services, community services, and general practice or community and physician services. Particularly if you think about the demographics of our population and the ageing population, what we also understand from our statistics is in relation to the care of older people, the risks increase exponentially. So in terms of safety incidents, we know that 73% of adverse events occur in the over 75s, requiring some degree of intervention or an extended length of stay. So morally and ethically, while harm prevention is crucial to safeguard people, what we also know in terms of balancing the figures and the costs associated with healthcare delivery, we need to get it right first time, every time, to manage and contain costs. This is a slide that you should see there in terms of reference to the Mid Staffordshire Hospital. This experience that occurred between 2000 and 2009 should come with a health warning and should really encourage everybody to recognise the risks associated with systemic failure. You see in the top left there a report document, and it makes reference to volume 1. There were 5 volumes. The government in England initiated a public inquiry. That's the highest level of judicial inquiry that can be invited by a government. It was conducted by a barrister of extreme eminence and experience, Sir Robert Francis, who conducted that public inquiry and invited view from patients, families, clinicians to understand what happened in that organisation, the failures that occurred. And at the heart of that inquiry was an identification of a board, a executive team who became focused on finance rather than safety and quality. What was also interesting about that inquiry, it identified that within that organisation there were pockets of absolutely exceptional care, exceptional clinicians, allied health professionals and nursing staff providing exceptional care. But elsewhere within the organisation, there was a lack of compassion, a lack of care, and a failure to engage in peer review and peer critique to affect improvements in the safety and care of patients for whom they were responsible. In response to that government-led inquiry, the NHS England and the government invited Don Berwick from the Institute for Healthcare Improvement in Boston, the US, to provide a response. Don Berwick, amongst and together with a number of clinicians and lead safety advisors, produced a report called A Promise to Learn, A Commitment to Act. And that is the framework for which safety improvement is currently being conducted here in England. And it identified the relationship between staff well-being and safety and patient outcomes, the importance of hearing from staff, raising their concerns, the risk of leaders not being visible within the organisation, and very much a focus on human factors and ergonomic science to improve system understanding and safety improvement. And at the same time that the Berwick report was produced, this document, Human Factors in Healthcare, a concordat from the National Quality Board, was also produced and launched. And I think it's fair to say, in relation to the Mid Staffordshire inquiry, there was a number of reports and investigations over time. And in 2010, our then medical director, Sir Bruce Keogh, identified some of the concerns that he had and established a reference group of expertise, academics, researchers, clinicians who had an interest and experience and work in human factors and ergonomics to advise the ministry on what it should be doing. And so I would invite you, if you're interested, to Google this report and look at the number of recommendations that were made that need to happen both at the system level in terms of what a ministry should be doing to bring about change, but also what should be happening within individual organisations. What we actually identified from the work that we've been doing, both within the Mid-Staffordshire failures and also looking at what we were learning from national reporting of harm, is that there are many sources of system error and failure. Firstly, if you think about the complexity of the health systems in which we work, we have multiple players with potentially different goals and assumptions. Our challenge is, however laudable our ambitions, safety features and defences do become degraded over time, so we need to be attending to those continuously. And for the most part, we have a challenge in managing demand and capacity in our health systems. So our environmental conditions, the expectations of the service and the demands of people who are delivering that service change over time. And that can be from minute to minute, hour to hour, and day to day. Our reality is our actual operations and the way in which we conduct services are far more complex than our design models. Intriguingly, system elements interact in unexpected ways. And whilst humans are fallible, they're also incredibly creative and versatile. So we need to recognise that procedures, tools and materials are often used in ways that we really don't anticipate. My career was historically, clinically, within the operating department, and I've seen how creative and adventurous staff can be, often in unpredictable circumstances. So to understand why human factors is important and to understand how this can impact on the extent to which we can provide compassionate and safe care requires us to recognise the research. I've just got some detailed here, and there's much more. The behaviours contributing to error and harm, and they are as detailed on this slide. Failures in decision making, challenges around teamwork, challenges around interpersonal skills, lapses in situational awareness, issues around coordination and cooperation, elements of leadership, and then inconsistencies in process and procedure. And while I focus on this slide here to identify those individual performance-related issues, the non-technical skills of professionals, whatever their background, is that this is just one dimension of all that we know around ergonomic and human factors science. So some of you on the call, I hope, will be familiar with the work of Professor Jane Reid and his contribution to safety understanding. And this slide really captures his observations around collective mindfulness and the notion of humans as hazards and humans as heroes, and really qualifies and invites us to recognise the role that staff play as the buffer in the interface between carers and patients and the systems in which they work, and how the extent to which they can buffer those challenges, absorbing harm, mitigating risk, really contributes to the resilience or not of the systems in which we work. So on to compassion. What's the relationship of compassion to human factors? Well, I've been engaged in this work for some time, and for me they are inextricably linked. So just for context and some definitions here and some observations, compassion is described as healthcare's most precious asset. It's a fundamental element of healthcare and one of the strengths of the profession. And importantly, many would argue in the absence of compassion, what we actually are providing is hollow care, technical care, but a failure to connect with the human being. And we need to recognise that our increasing focus on science and technology contributes to this challenge. Equally, with the focus on lean performance management, there's been a danger that some elements of lean methodology have been cherry-picked, which contribute to the challenges we experience. What I guess I'm really saying here is that while lean can assist us, it can support us in driving continuous quality improvement. It can certainly assist us in driving performance, focus on productivity. People are not widgets. And clearly people on the call will come from different health systems around the world. The way in which we understand our demand and our capacity to respond to demand will vary considerably. And what we need to recognise for the most part is in production engineering and how we understand lean, is those organisations do not work at 100% capacity because of issues around back pressure and failure of performance. But here in England, a publicly funded health system, we have considerable demands of our health system. Anybody who might wish to look at our current media reporting will be very aware that it's high on the political agenda, and there's considerable attention being focused on the quality of performance and the sustainability of service, and significant cost pressures given the way in which our services are funded. One of the challenges we have around ensuring that care is compassionate and well supported, and ensuring the appropriate care is provided for patients, is that everyone will have their own personal definition. Personal definitions fit in with our own view of the world. It may have little to do with or have anything in common with the people with whom we work. So human factors really can help us, and CRM, crew resource management training, situational awareness, a whole range of tools and techniques that we might employ can assist us in developing shared mental models, so that colleagues are on the same page and committing and pulling in the same direction. So just some references there to make particular focus on shared mental models, which is defined as the perception of or understanding of or knowledge of a situational process that is shared among the team, and importantly is achieved through communication. So compassion, if we think about what we might want for our family members and what we might want from ourselves in terms of compassionate care delivery, involves generosity and kindness, valuing otherness, awareness and recognition, honesty, and dialogue. The one thing I would say, and it's a takeaway message, is that there are 3 states: past, present and future. And one of our greatest challenges as health professionals is to remain present. But unless we're present with the patients that we're caring for, we're likely to be delivering quite hollow care, because it's disconnected and has no real heart at its source. And that's just imagery there, implying with the lady with the junior doctor there with her head against the wall, about the pressures of caregiving. And unless we recognise that the emotional burden of healthcare on those that provide care, we're missing a trick. Patient safety and staff safety and wellbeing are inextricably linked. Compassionate care is much more than the competent execution of clinical skills. It's not just about a doing role, it's not about technical performance, it's actually about being, it's about connectivity, and what we all have to recognise for patients, particularly at times of trauma, times of distress, and that they feel cared for and cared about. Patients rarely question the technical elements of their performance. Most complaints, most challenges that we have about our service relates to the human dynamic, the communication dynamic. So what I invite colleagues on the call to recognise is that for us to engage as professionals, there are 2 elements that are really important. How we engage with people instrumentally, so how we apply our required skills and knowledge, but then secondly, really more importantly, and for patients that is, the emotional aspects of the relationship between the caregiver and the person in receipt of care. What we know from all the findings of the failures and some of the institutional failures I've described, in terms of the individual case failures from the variation in care that I've described, is that where staff have not been supported appropriately, they have suffered compassion fatigue, because the emotional labour of caring has just proved too great in the absence of appropriate support. And what we do need to recognise is that compassion fatigue sits on a continuum of post-traumatic stress disorder, and ultimately what we're looking at, if that is not addressed, are challenges around burnout, stress, and ultimately people leaving the service, which is not good for them or for patients. So what contributes to those challenges? What contributes to compassion fatigue? It relates to the conditions in which people work, the nature of their work, and most significantly, the one standout feature of the Mid-Staffordshire inquiry and the failures in that organisation was the experience of staff repeatedly going home from work each day with a sense of foreboding and an inability to give of their best, because the hierarchy, the conditions within that organisation just prevented them from doing so, and that really contributed to their challenges and their failure, their feelings of failure. In terms of resilience, what can make a difference, what contributes to compassion fatigue or supports staff to be more resilient and able to deal with the emotional labour of caring, and relates entirely to human factors and system factors that we understand. There are issues to do with experience, the way in which we train and prepare staff, the supervision we provide, the level of morale in an organisation, the mental and physical health of staff, and across most health systems now there's a concern about the impact of obesity and long-term conditions. We really do need to look at not just the wider health and public health of the population, but look at the obesity and mental and physical health needs of the staff that are meant to be providing care. Challenges around tiredness and resilience, as I've already mentioned. So, how can we strengthen compassionate caregiving, embracing human factors? We need to think about communication and being clear about what our role and definition and support for staff is. We need to acknowledge the challenges and the costs in health delivery, the human costs as well as the material costs. We need to adapt the lessons in leadership learned in other dimensions of patient safety improvement. We have to strengthen patients' and relatives' voice in the system and invite them to co-design and co-produce the systems and the services that we provide. And we need to develop managers' relational skills so they're interfacing with clinicians on a daily basis in an appropriate way that reduces conflict. So what I believe we need to move to is a shared mental model drawing on human factors understanding that creates a commitment and a vision of not on my watch, a commitment to an essential mindset that seeks to support staff, seeks to support patients, and really is less about compliance and about a pursuit of excellence, and really is about challenging any tolerance of mediocrity that we see where error and harm prevail. It requires all staff to take action. It requires all staff to engage in speaking up and speaking out, peer review and challenge of mediocrity. And that requires us to recognise that invites people to act and choose to be counted. And that does require courage and is dependent on the culture of the organisation and the climate, the safety climate that has been built. And ultimately, we require commitment of leadership at all levels of our health system, whether that's at the ministerial government level, whether it's at the level of the board. And we need to recognise that we have to make it easier for staff to do the right thing. So for me, there's some real synergies in how we deliver compassionate care, all that we understand from caring theory, safety science and human factors about present therapeutic engagement and the relationship between self, system and situation awareness. What does that require of us as individuals? It requires us to be counted, to practice in the moment, to be present, to be sensitive to sentences that are prefixed with just or but. So that's whether I've just got a concern or I'm just a nurse, which is devaluing and unhelpful. And we really need to create a climate where colleagues are invited to raise concerns and observations about practice, and we need to thank them and celebrate when they do that. So the research evidence tells us that where we can balance patient experience, clinical effectiveness and safety, we can deliver much better experiences for both patients and staff. Organisations are much more patient-centred, and they have much better clinical outcomes in terms of their mortality data. We know that triangle of relationship between safety, patient experience and clinical effectiveness also improves the relationships between caregivers and the patients in receipt of their care by improving the communication and the self-management of chronic conditions. And what we also know is it absolutely reduces anxiety and fear that can delay healing. Just detail out there the non-technical skills that we need to be focusing on and how they can support us. 3 takeaway messages. Whether we're a staff member or we're a patient, it's vitally important that we maintain identity and we see the staff member in the professional, the individual in the professional, and we see the person in the patient. It's absolutely vital to effect safety improvement. We create communities that invites people to connect together, share their experience and advance safety improvement. And ultimately, we should have a culture where there is no decision about me without me, whether I'm a staff member managing a change or improvement or a service delivery initiative, or whether it's about my decision making about my care pathway and what I'm about to receive. None of what I've described is rocket science. If we look at the synergies between compassionate care delivery, human factors and ergonomic science and understanding, what we do and what we can recognise is that if we value and take good care of staff, they're much more effective in their role. We have to reward and encourage leadership for care and caring and promote it actively. Everyone has a responsibility to role model professional behaviours and challenge unhelpful behaviours in the workplace. We have to promote effective communication at every level, and we have to recognise that no matter our role, our position in an organisation, it's the little things that make a big difference to both patients and staff. And I'll leave you with a picture of my dad. Regrettably, my father is no longer with me. He passed away and was the subject of a whole range of avoidable harm issues. My challenge is that I'm a nurse. I'm a health professional with insight. So wherever you are in your health system, I invite you to think, how do we protect the patients who don't have a nurse or a doctor or a caregiver as a daughter or a son or as a relative? How do we manage their care pathway, and how do we navigate them through the vagaries of the system that we currently provide? Because we have to get on top of the avoidable harm in our healthcare systems. Thank you, and I'll open the floor for questions and any points of discussion. Thank you.
Great. Thank you so much, Jane, for walking us through that. I know that we're approaching time, but we do have time for a few questions. So the first question from the audience is, though awareness of safety science and the importance of supporting frontline staff has gained traction over the past decade, many organizations are at the beginning of the journey in translating this to practice. What advice would you give to someone in that position? Where should you start?
You absolutely have to have executive sponsorship. Unless this is owned at the board level, it just becomes something that people struggle with. And what we know from our learning here in the UK is that invariably we have clinicians who understand this science and are seeking to advance it in their organisations in spite of the system, not because of it. So executive sponsorship, ownership at the board level is vital.
Great. And next question, are there any examples that you've come across either inside of the UK or outside of the UK of organizations that we can look to for best practice around human factors?
There are. I mean, obviously, I'm familiar with organisations in the UK, and as you say, it's an emerging application, and we still need to look to other safety critical industries to inform what we do in healthcare. But there are organisations in the UK. I can cite several I've worked with recently that are starting that journey. There's still, there's a long way to go, but there are a number of organisations, Guy's and St Thomas's in London, Salford Royal, number of organisations in Manchester and Nottingham in particular, Merseycare, fantastic work around forensic mental health that are really embracing the science to support staff and to support the systems inquiry that they need.
Great, and I think a last question would just be finally if there are 1 to 2 key takeaways or recommendations that you would like participants to walk away with, what would those be?
Two things, and it's really important that we hold on to them. What we permit, we promote, and there is a risk that unless we challenge through peer review and constructive review, and that we collude and we create a whole set of assumptions about what's acceptable in terms of mediocrity. So what we permit, we promote, and ultimately the standard that we are prepared to walk past as professionals is the standard that we choose to accept. So if we're about safeguarding patients and promoting appropriate work practices to support staff who the quality of care ultimately depends, we have to recognise where the standards sit and what's important and how we maintain a commitment to the standards that we value.
Great. Well, I think that I have no better way to conclude that. So I'd just like to go ahead and thank you so much, Jane, for taking the time to share that with us today. And thank you for everyone for dialing in and joining.